issues arising in pancreas cancer in terms of improving patients' outcome, the biggest challenge continues to be that we haven't broken the 1 year line of median overall survival for patients. We've done a lot of improvements. I think we went from a 3 to 4 month survival to now close to 10, 11 month at the median. So we've made some significant improvements. So for some patients, that translated into 5-year survivals of for some patients to survive 3 or 4 years, about 3 to 4% of those patients, whereby in the past we never had anyone go beyond 2 years. So we have some patients being able to go for much longer with the treatments, with the more modern treatments. Unfortunately, after a series of few successes over the last 5 years, let's say since 2010, in the last year and a half, we've had a lot of disappointments. A number of combination therapies failed to produce the results we were hoping they would produce. One example is an agent called ivosfamide combined with gemcitabine failed to improve outcome versus gemcitabine, although the phase 2 randomized data looks promising. Another example is our 2 studies, actually. One study specifically, Janus 1 and then Janus 2, looking at capecitabine plus ruxolitinib, which is a JAK inhibitor, also did not show an improvement in a pre-specified patient population. And more recently, we've also come to learn that 2 trials were negative to immunotherapy trials. Immunotherapy is all over the place. The excitement about immunotherapy across multiple malignancies is obviously producing results. And pancreas cancer has not translated into such results. So L-Gempanticel-L, which is a hyperacute vaccine in the adjuvant setting, did not show any benefit when added to gemcitabine. And then CRS-207 and GVAX, another combination of vaccines and vaccines enhancer, which seemed to be very interesting in the phase 2 randomized study, came back also negative. So a series of setback, and thus the challenge continues with this disease in terms of further improvement and drug development.
So the development of the prognostic and predictive biomarkers has been very slow in this disease. And in fact, we don't have biomarkers, molecular biomarkers that we have in other cancers like breast cancer or lung cancer, which are also solid tumors we treat. So we have been struggling in terms of developing ways to segregate patients in terms of which patients to treat with what drug, and then using different drugs in others. So at this point in time, I would say that we don't have really good biomarkers that help us to either predict response or the prognosis of patients that we treat. There are biomarkers that are being developed at this time, but none of them have really been tested in a way that I can say for the practicing community oncologist going to use this biomarker.
So the role of the microenvironment in pancreas cancer and its pathogenesis is better understood now than it was before, but we still are trying to understand how to target this microenvironment in the clinic. Preclinically, we have a lot of data, meaning in the lab, we understood a lot of the intricacies of that, for example, fibrotic reaction that just is like a fortress sitting around these cancer cells, these pancreas cancer cells, which essentially makes it very difficult for chemotherapy to penetrate. It also, that microenvironment involves immune cells that are what we call suppressive, meaning they essentially suppress the immune system from attacking the cancer. And all the good cells are actually out of that fortress. There's also very little blood supply. These tumors are hypovascular. And thus, delivery of immune cells, good immune cells, or chemotherapy is very challenging. So what we're trying to figure out are ways to actually break down that barrier. And a number of strategies in the past have attempted to modify some of the barriers. More recent developments suggest that breaking down hyaluron, which essentially is almost like the glue that keeps this fortress solid, an agent called PEG-PH20, which seems to be mostly active when this protein is expressed at high levels, has shown some promise and is moving into the phase 3. So we're understanding a little bit more about the microenvironment. The problem, again, is mostly how do you just break down that microenvironment so your immune therapy may become more effective, your chemotherapy may become more effective, other strategies as well target strategies may become more effective. As long as we haven't figured out how to break these barriers, it's going to be very difficult to, one, attack the cancer and two, modulate the microenvironment.